Okay, I think we have to start working. So we are going to start with the scientific program. And we are really delighted and really happy that to start this event that, as you know, we are somehow very much centered into EGFR mutated disease. In fact, and we will discuss a bit later, it is our opinion to review EGFR mutant disease, and we are hoping with the discussion we are having all through the day to have a consensus that we will try to, after the meeting, to further circulate among the people here to try to get a consensus on how to treat it. So without further delay, I'm just going to invite one of, maybe not one of, but the rock star of EGFR mutation, and is Professor PJanne, all the way from Dana-Farber, and he's going to illustrate us how combination may help to overcome resistance in this disease. So, Pasi.
I want to thank the organizers for inviting me. It is my very first trip to the Canary Islands, and it's been beautiful so far. So I wanted to talk a little bit about some of the strategies that we're trying to take to overcome specific types of resistance to EGFR inhibitors, and there'll be a lot of discussion in the subsequent sections as well on this. So these are my disclosures. So this is a fairly typical series of scans for any of our patients receiving a targeted therapy. This is a primary mass. There's other metastases. A person's treated with a targeted therapy, and you can see a very nice response, but not a complete response. And ultimately, resistance often emerges from this residual disease, often. And this is a population that's often referred to as the minimal residual disease or the drug-tolerant state, because this population of tumor cells was able to survive the initial EGFR inhibition, and true for all targeted therapies. And that is something that we've been interested in trying to understand a little bit better and develop strategies to eliminate. And this is sort of a summary slide looking at resistance, and you can think of it in sort of two different ways. One is that resistance can come from a pre-existing resistant clone, is that it's selected over time with targeted therapy, and described for EGFR T790M when we had first-generation EGFR inhibitors, and it's described for MET amplification as well. Or it can happen from this intermediate state, this state that survives the initial insult of drug inhibition, and out of that state, ultimately over time, a plethora of resistance mechanisms can emerge. And so one strategy would be to develop better initial therapies, and I won't talk about this because I know it's in the rest of the program. It will be discussed about initial combination therapies, such as with chemotherapy or other combinations that could perhaps have a greater effect initially and thus delay or prevent this sort of intermediate state from happening. I'll focus a little bit on how we're trying to approach this state and to try to develop specific strategies to inhibit it. And a couple of years ago, we did some studies of this drug persistent state and showed that it has some features of cellular senescence. They're not truly senescent cells, because true senescence is irreversible. This is a senescence-like state because if you remove the drugs in vitro or from a patient, the cells start to regrow. They're able to survive that therapeutic insult. But there is a whole field of medicine looking at trying to study and inhibit senescent cells. As we all age, it's become an interest of trying to understand what is it that leads to senescence, and how can you treat senescent cells. And there are a whole series of drugs that are referred to as senolytics that have been tested in the aging field. And so we tested some of these in these EGFR inhibitor models. So we treat, for several days, we treat cells. This is just an in vitro experiment with EGFR inhibitors. And then at following treatment, 10 days, we'd add a second drug and ask, can we now selectively induce cell death? And this is measured by a fluorescence probe in the cells that remain. And when you screen a bunch of cells, the drugs that really work in this situation are those that inhibit BCL-XL. BCL2 inhibition by itself doesn't do anything. BCL-XL inhibition works, as does agents like navitoclax that inhibit BCL2 and BCL-XL and others. And these have actually been tested in the clinic. We participated in this clinical trial some time ago of combining osimertinib and navitoclax. This was at a time when osimertinib was only approved in the second-line setting for patients with EGFR T790M. And in this phase 1 trial, these are all patients with EGFR T790M. They had good responses. Now, would it have been better, or is it better than osimertinib alone? Hard to say. This was just a signal-seeking study. And if you looked at patients who got in the expansion cohort, all of these patients, all of them had essentially ctDNA clearance if they had pre-treatment ctDNA present. However, navitoclax is no longer in clinical development for solid tumors, partly because of toxicities, thrombocytopenia being the main toxicity, and of course, osimertinib can lead to thrombocytopenia, and we did see thrombocytopenia in this study, and that was one of the reasons it didn't move forward into a bigger study. Now, there are new agents, and this is work we've done with AbbVie, that have developed essentially an antibody-drug conjugate, which is an EGFR antibody conjugated to a BCL-XL inhibitor. The idea would be to try to deliver this in a more targeted way to tumor tissues and potentially avoid systemic toxicity, and in that way perhaps have a wider therapeutic index. And in the studies that AbbVie has done in combination, for example, with chemotherapy, they see very good effects. And when they measure platelet reduction, when they measure platelets with a small molecule BCL-XL inhibitor, you see significant platelet reduction, but with the ADC you don't. So it at least gets rid of that potential problem. So we then tested it in a in vivo model where we treat EGFR mutant tumors either with vehicle or with osimertinib for 3 weeks, and at the end of the 3 weeks, so once this sort of drug-tolerant persister state has formed, we then continue half the mice with an EGFR inhibitor, and the other half we add this BCL-XL ADC for another 3 weeks. And at the end of that time, so 6 weeks into it, we stop all the drugs. And the idea is that if you've now done anything to this drug-tolerant persister state, adding this ADC, there should be a delay in the outgrowth of the resistant cancer, or hopefully none at all, but we don't usually see that. So in this experiment, we can see that this is what we've now done the treatment. This is where we stop the treatments, and with the EGFR inhibitor alone, all the tumors ultimately, or the vast majority of them, grow back, but we see a significant delay when we add the ADC, and this is the individual animals. You can see some with EGFR inhibitor alone in this model that are appreciably don't grow back, but there's many more of them in the combination. And in fact, in the combination, we can cure in this experiment at least, cure more of the mice, i.e. the tumors never grow back, than with osimertinib by itself. And you can see in some of the this is a good way to look at these residual tumor cells, because you have antibodies that specifically detect the exon 19 deletion EGFR, and so you can see that in the residual disease you can have normal, stromal infiltrates, but easily identifiable tumor cells, and you can use this to isolate the tumor cells as well. And this is another model. This is in a patient-derived xenograft model. Same idea. Here's the ADC treatment, and at the dotted line, the therapies are stopped, and these curves do separate still, but unfortunately, ultimately, they do start to regrow. So, and we're trying to understand why that may be the case. Are there other anti-apoptotic proteins like MCL1 that can also play a role here? And is the duration of the treatment, here we only gave it for three times in a human therapy, or you would probably give it continuously, so does that make a difference or not? So we don't know. And ultimately, is this something that we could translate into the clinic? Now, this compound is in the clinical development called ABBV637. And at the ESMO meeting a couple of years ago, my colleague Julia Roto presented the phase 1 trial where this agent was combined with either docetaxel or with osimertinib. In combination with osimertinib, it was actually relatively well tolerated. There's some LFT abnormalities, but no other major toxicities, no thrombocytopenia, no significant thrombocytopenia. And the patients that were treated in the expansion cohort were all patients that had progressed on osimertinib, where we wouldn't necessarily expect a lot of activity, but there were some responses even in this combination in that patient population, enough that I think there's interest to maybe move this concept forward, and we're working with both AstraZeneca and AbbVie to try to bring this combination forward, either giving it following maximal response to osimertinib or at the time of initial treatment. So that's a potential unique vulnerability in this persister cell state. And we have started to now more extensively analyze these cells, both from patient samples and from model systems. So from patients, we've had a few patients that us or our collaborators have received neoadjuvant EGFR TKI or with the explicit intent of undergoing surgery, or just having a good response and having a resection of the residual mass. And this is just one example of that. And we've tried to look at cell surface proteins where we could potentially target that could be unique in this DTP population. And it turns out that TROP2 is one of those proteins. It's present in, this is the gene name for it, and this is on single-cell RNA sequencing data, and this is by immunohistochemistry. It is present, as you know, in pre-treated cancers as well, but it seems to be a little bit enriched in cancers that have been exposed to EGFR inhibitors. These are studies that were done using a kind of the mouse equivalent, so these are different mouse models, and we treat them to a maximal response either with osimertinib, or in this case osimertinib and a MEK inhibitor, sacrifice the mice and sample the residual tumors, and then do different types of analyses on the residual tumors, again focusing on cell surface targets which could be exploited therapeutically. And this is an example of that in a model, and here this is TROP2, that is one of the most highly enriched genes expression compared to baseline. And there are other potential targets, folate receptor, others that are enriched as well, but we've focused on TROP2. And this is by looking at it from those tumors at the time. This is vehicle treated, osimertinib treated, or the combination treated. And you can see that in green, you can see TROP2 at baseline, but in these MRD or DTP populations, there are some that are very, very highly upregulated, and others where it's not that different from what we see in the baseline. And of course, we focus on cell surface targets because there are drugs against cell surface targets. ADCs, for example, we all know about datopotamab deruxtecan and sacituzumab govitecan. This one approved in triple-negative breast cancer. This one extensively studied in lung cancer, and appears to work particularly well in patients with EGFR mutant non-small cell lung cancer. This was from the ESMO Asia meeting. just a month or so ago, where the pooled analysis of the Dato-DXd treated patients from the Tropia and Lung-01 and 05 clinical trials were done, and could show that in the patients with EGFR mutant lung cancer, there's a 42% response rate, and similar whether or not you've had prior osimertinib or not. And so we've decided to test out whether treating this MRD population with a TROP2 ADC would be useful. Here we used sacituzumab govitecan because that's an approved agent and that's easier for us to source. But we again treat mice, same idea, treat them with a maximal response, and then at the maximum response we give them the TROP2 ADC, and at this point we stop the treatment and look for regrowth. And you can see that there is some difference in the green versus red, but it's not that dramatic. And if you look at sort of regrowth endpoints, there's some improvement by giving the ADC, but it's not that much different than the EGFR TKI by itself. So we decided to turn to another approach, and that was to try to see could we use some sort of immunologic strategy. And we worked with Eric Smith and Elliot Brea, who are working on various CAR T cells at Dana-Farber Cancer Institute, and decided to use the same antibody binding epitope or motif that is in the sacituzumab govitecan, but constructed into a CAR T cell. And did the same experiment again, where we treat the mice with the maximum, and we could show that the CAR T cells are very effective in vitro. So, and then show that treat the mice, then either treat them with sacituzumab govitecan or with a CAR T cell, and then withdraw the treatments. I will note that the antibody, either in sacituzumab govitecan or the same that's used in the CAR T cell, does not recognize mouse TROP2. So you can't evaluate this for toxicity. And here we again see the green shift away from the red, but this is the TROP2 treated animals, the CAR T cell treated animals, and you can see that there are many more that we can cure or have many more significant durable responses. And again, if we look at the outcome of the mice, this is by far the best combination. So it serves as a proof of concept. I don't think it is ready for clinical prime time yet, but I think as a proof of concept that you can potentially target some cell surface targets in this population of surviving cancer cells, and potentially that can have a therapeutic impact. So this is the population we've been focusing on, the drug-tolerant persister cells. This is the sort of nidus that gives rise to resistance over time. They have some unique biologic properties and express potential novel cell surface targets, and this can be leveraged therapeutically. And you can treat these, or you can hopefully prevent them from happening in the first place by better initial combination therapies, and I know talk about that more today, but still certainly clinical validation is needed. So I just wanted to acknowledge many of the individuals in my lab who, Simon and Francesco in particular, who led many of these experiments. Our collaborators, Eric Smith, Elliot Brea, Dave Barbie in his lab, our collaborators, clinical collaborators, as well as our bioinformaticians and Belfer Center, where we do a lot of our in vivo PDX studies. So, and of course the people who pay the bills. So with that, I will stop, and I'm happy to take any questions. Thank you again for the invitation to be here.
So, looking at this issue of persistent cells and so on, when you treat with for example, with the venetoclax or those drugs, I mean, you're still having some persistent cells after the treatment.
Yes, It may be much more complicated than we're thinking about, and that's why we're focusing on other anti-apoptotic proteins that could complement for BCL-XL or some of these others. It may not be the whole story, it may be part of the story.
All right. So have you really looked at the impact of those, let's say, senescent cells, those that are senescent cells? What is the impact on the microenvironment? In some other models, it has been seen that those are really the one provoking or facilitating tumor evasion. Have you got any data on that?
We have not looked at that yet, but it is something that we are starting to look at in more detail, the microenvironment. It's, you can do some of that using in vivo models, but all of our PDXs, of course, are grown in immune deficient animals, and so you can't answer all the questions you'd like to. It'd be wonderful to study from patient specimens, and hopefully from some of the neoadjuvant clinical trials where patients undergo surgery, that would be a place to do some of these studies. And we're keenly interested in doing that.
Okay, thank you. So here, Dr. Lopez Picasso.
I tried to say, my name is Marcelo Manotti, Summit Therapeutics. I had to discuss about doing ivonescimab for palsy as the beginning of the treatment, as we do have now information of the harmony trial as a relapse setting.
Right. In the Harmony trial, in the relapse setting, chemotherapy plus ivonescimab was better. Yes. Yeah.
The combination from the beginning, because we've seen that in the past, checkpoint inhibitor is extremely toxic.
Right. So I think you'd have to test that combination first to make sure it's tolerable before moving it forward. But not something that we've modeled preclinically. Again, we're dealing with immunodeficient mice, so we have not done no.
If you have any questions, you can approach us. Happy to discuss this.
Sure. Thank you.
So about the small cell transformation, you would suggest or you would think that probably those cells are coming from the persister cells, right? Or maybe not necessarily. But do we have any data regarding the biology behind that transformation? Would you think that is related to the tumor per se, or the treatment that the patient has been exposed to? What are your thoughts?
Well, the small cell transformation, which happens in the 10-15% of patients treated with osimertinib, which I think is clinically one of the more challenging ones to treat. If you analyze the small cell in those patients, the tumors all contain the EGFR mutation, so it had to have originated from the same population that gave rise to the adenocarcinoma, and they typically also have p53 and RB loss. And in fact, if you have that constellation at diagnosis, an EGFR mutation, p53 loss, and RB loss in your tumor, the likelihood of developing small cell transformation is 40, 50 times greater than if you don't. And so clearly those are necessary, but what else mediates that? I think we still need more information on. Because if you, for example, take an EGFR mutant lung cancer cell line and delete RB and p53, it doesn't become small cell. It does require something else, something probably adaptive as a response to the treatment in the context of those two other genetic alterations. So I think more needs to be done there, and including asking, do our therapies that are successful now, like tarlatamab and others in treating classical small cell, do they have a role in treating patients with EGFR transformed small cell?
Okay, thank you very much. Last question here, maybe.
Thank you for your talk. Just a little from
Hi, Jess.
So you've thought a lot about how to bring hopefully the interventions targeting persister cells into trials. And one of the challenges that you touched upon with when you were talking about the BCL-XL directed ADCs, the timing, right? Do we start those upfront together, or do we bring the additional intervention in after some time on the initial therapy? You've spent a lot of time thinking about this. Can you share with us, what your approach has been, or what you think is the best path forward?
I don't think we know that. I think you can test both contexts and ask, do you, if you start those combinations from the beginning, do you see a deeper responses, for example? Or if you use them after maximal response, typically, as I showed you in the CT, you still see something there. Now, if that's the maximal response and you add another agent, does it shrink further? Would be another way to look at it. And so I think these are ways to test it in the clinic once we're there.
Okay. Thank you very much, Pasi. I think we're going to move. We're a bit delayed with this session, so thank you very much.
Thank you again.